On behalf of Department of Gastroenterology and Human Nutrition Unit, I welcome you all in the CPC. And today's case will be discussed by one of our illustrious alumni, Dr. Usha Dutta. She is now heading the Department of Gastroenterology at another prestigious institute of North India and India, in fact, PGI Chandigarh. And we have a very interesting case, and I think Dr. Prasenjit will take over from me. He will be conducting the CPC.
Thank you, Dr. Saraya, for your kind words.
So, respected Dean Madam and all seniors and respected faculty and students. So we are starting today's CPC. As Sir already introduced ma'am. She is very well known in the field of gastroenterology, and just to mention, she is a member of the National Task Force on Celiac Disease and Irritable Bowel Syndrome, and a fellow of American College of Gastroenterologists, and governing council member of the Indian Society of Gastroenterology and INSL. And just to mention, she is having 39 ongoing projects and will be beneficial by her vast experience. So may I request ma'am to please share your screen and start with the clinical discussion of the case.
Thank you, Dr. Prasenjit. Thank you, Professor Saraya, for your kind introduction. Today's case is an interesting case. Am I audible?
Yes, yes ma'am.
Yeah. Yeah, today's case is an interesting case, and with this I bring these are our memories of colorful holy celebrations of the 1984 batch. You can see Dr. Sneh Bhargava, Dr. Rajan Tandon, Dr. A.K. Malviya, and Dr. P.N. Tandon all here. So we had great time with times in AIIMS. This particular patient is a 60-year-old lady doctor from Allahabad, who has presented with recurrent vomiting for the last 4 years, upper abdominal heaviness for the last 4 years, intermittent rolling bowel movement for the last 1 year, weight loss for the last 1 year, and reduced intake for the last 1 year. She had recurrent vomiting, which had started insidiously about 4 years back, used to occur infrequently, once in about 4 months, and it was associated with postprandial upper abdominal heaviness, self-induced vomiting, after which there was relief of symptoms, and she was asymptomatic between the episodes. There was no anorexia, weight loss, distension, obstipation or constipation. Her routine blood work was normal. Upper GI endoscopy was unremarkable except for a few erosions in the stomach. And she was treated with PPI and prokinetics with satisfactory response. She remained relatively well till 1 year back, when she started having progressive worsening of her symptoms in the form of increased vomiting. Initially, the frequency was 1 to 3 months, and then became once in 10 days, then once in 3 days, then daily for the last 1 week, requiring IV fluids. It was associated with postprandial discomfort, intermittent bowel rolling feeling on the abdomen, and relief with self-induced vomiting. She also noticed significant weight loss of 8 kg. There was no nausea even now. There was no pain, no obstipation, constipation, or abdominal distension. There was no headache at any point of the illness. She had significant past history. She had hypertension. She was on losartan 50 milligram once a day. We do not know the control status and the duration of hypertension. However, in 1988, she underwent an open appendicectomy and a cholecystectomy. In 1989, she had a left renal cell carcinoma. We do not know the nature of the lesion. In 1989, she underwent a left nephrectomy with a local radiotherapy to the renal bed. In 91, she had pulmonary tuberculosis and took antitubercular therapy. We do not know the status of the response or the basis of the diagnosis. In 2011, she underwent bilateral knee replacement. We do not know the history of NSAIDs taken at that point of time. There is no history of diabetes and no family history provided. Investigations were essentially normal. Hemoglobin, please note that it was essentially normal. There was no leukocytosis, no thrombocytosis. LFTs were normal, and alkaline phosphatase was always normal throughout the course of illness. CRP was never elevated throughout the course of illness, and the rest of the investigations were normal, and there was no hypercalcemia. Renal functions were normal. She underwent investigations in Allahabad in the form of an upper GI endoscopy, which showed some gastric erosions, an ultrasound which showed that the left kidney was not there because of nephrectomy, and the right kidney was enlarged, but there was no focal lesion, and it had a normal parenchymal ecotexture. Gallbladder was absent due to cholecystectomy, but CBD was prominent with a smooth tapering till the lower end, no IHBR dilatation. She was also found to have an incidental small intramural uterine leiomyoma. EUS was done, which showed essentially just a mildly dilated CBD with a normarine tapering at the ampulla, and side view endoscopy was normal, and pancreas was normal on the EUS. Serum gastrin, thyroid function test, vitamin D, vitamin B12, lipid profile, HbA1c were all normal. On examination at admission now in September 2020, her height was 160 centimeter, weight was 57.5 kg with a BMI of 22. Rest of the clinical examination was unremarkable except for the two scars, the subcostal incision and the subcostal incision on the right side, and also on the left side, suggestive of the previous two surgeries. There was no lump in the abdomen. During hospital management, her laboratory parameters were again found to be normal. She was started on IV antibiotics, IV fluids, and liquid diet. CT suggestive of adhesive partial small intestinal obstruction. She was given an oral gastrographin challenge on 23rd of September. And here we have the CT films of this patient. The CT film shows that the stomach is hugely dilated. And as we go down, we find that the duodenum is also dilated. This is the duodenum, which is dilated. And then we are started seeing a prominent CBD in the head of the pancreas. And as we see the prominent CBD, we also find that the pancreatic duct is mildly prominent, but rest of the pancreas looks normal. And this is the second part of the duodenum, which will be crossing over to the other side. And we can see that the remaining part of the duodenum, this is the duodenum, which is all dilated. And we can see it is significantly dilated at this time, and the SMA and the SMV are displaced to the left. And we see the remaining part of the duodenum crossing over the midline. And as we see on the left side, we are seeing that here the loops of bowel are clumped up. There's increased vascularity of the mesentery, and the bowel walls are thickened. So there is segmental thickening of the bowel wall, especially we can see that this one. And there are many multifocal thickening of the bowel walls of the jejunum with a clumped up jejunum with increased mesenteric vascularity. There were also a few lymph nodes there. And here on the coronal cuts, we can see that there's evidence of adhesive intestinal obstruction. There is dilated loops which are all stuck up with each other. And as we go posteriorly, we can see that here again, the mesentery is fairly prominent, and most of the jejunal loops are shifted to one side, and the descending colon is shifted right to the left as well as anteriorly. And as we go down here, we can see the hugely dilated duodenum and the jejunum, which is crossing over here, and this is ending up in the clumped loops, which are also showing thickening of the wall. And note that the thickening of the wall is not particularly hypervascular at any point of time. And we can't see any deposits in the mesentery. So here, as we go on, here you can see particularly a thickened bowel loop. So these were the CT films which are provided. So a dilated jejunal loop, and we can see that there is evidence of a thickened concentric thickening. There is a little bit of asymmetry in it, and there are multifocal sites of such kind of thickening of the bowel. And here you can see all the bowel loops are clumped up together. The CT scan is very important in this patient's differential diagnosis. That's why we have spent some time on it. So the CT and the gastrographin end up showing us that the patient had jejunal obstruction, which was segmental involvement. That is 5 to 25 centimeter of the segments are involved. There's multiple site narrowing of the proximal jejunum. There's mild circumferential wall thickening. In certain areas, it is asymmetric. There is no mural stratification. There is no edema of the mucosa. There is mesenteric fat stranding. There's mild vascular prominence in certain areas, suggestive of a Coombs sign. There is evidence of adhesions, and the rest of the gut and other organs are normal. Given this scenario, our differential diagnosis on such a kind of CT picture is adhesions, radiation-induced strictures, metastasis from from the RCC, Crohn's disease, or a low-grade lymphoma. And here are the gastrographin studies, which shows that within 10 minutes, there is dilated jejunal loops. And after 3 hours, the contrast has gone into the ileum. And here we are having residual dilated loops. And at 8 hours, it has gone into the colon. And there is only residual dilated loops in the left lumbar area. So what did the treating unit do? On 23rd of September, they gave an oral gastrographin, found a dilated jejunum and a transient holdup. So patient was taken up for enteroscopy on the 25th, which again showed a dilated stomach and a duodenum. Patient could not tolerate the procedure, so it was abandoned. Then underwent a PET CT, which showed no abnormal uptake. Then underwent an X-ray, which showed a dilated jejunal loops, and was taken up for surgery, explorative laparotomy on the 6th of October. The PET scan, which was done prior to surgery, showed that this is the normal cardiac uptake, normal renal uptake, and normal brain uptake. And you can see a few hilar lymph nodes, and it was reported as normal. However, we will like to discuss this in a little bit of detail. And here we can see that this area is not looking entirely normal. There are some areas of FDG avid areas, which are not very specific, but to a closer examination, these seem to be significant in light of this particular patient's history. And these uptake at the gastric fundus is suggestive of an area of inflammation because of chronic stasis. There could be some erosions which were also found on endoscopy. And these hilar lymph nodes have to be interpreted in light of the fact that patient had pulmonary tuberculosis and was treated. And the second thing is we do not know whether these are metastatic in nature. So the PET showed a normal uptake in the right kidney. We discussed what was there in the stomach and the hilar nodes. Jejunal loops were showing mild increase in uptake, whether it's vascular because of increased vasculature, because of inflammation, or non-FDG avid malignancy, we do not know. We would like to discuss that. So maybe we are overreading into the PET scan. It could be a low-grade lymphoma, which is also usually PET negative. NETs are PET negative, RCCs are PET negative sometimes, and GIST are usually PET negative. However, we did not find any mass lesion or any GI bleed in this patient, so this seems low likelihood. So a low-grade lymphoma, a neuroendocrine tumor, and an RCC are three possibilities given a PET negative status. So how do we move forward? If we look at the clinical summary of the patient, this patient has had various time points in her illness, which was separated by a gap of nearly 30 years. And here we have had an open cholecystectomy and appendectomy in 1988, and then an RCC and a nephrectomy and a radiotherapy in 89. And then in 91, a pulmonary tuberculosis, which was treated. And then partial gut obstruction starting from 2018 and worsening and progressively increasing and presenting, requiring surgery in 2020. So starting from the first thing she had, that was open cholecystectomy at the age of 28 for presumed gallstones. We do not know the indication. We do not know her parity. But gallstones in young, in our study, we have shown that 17% of gallstones in India are young in a series of 501 patients, which we have just analyzed. In the West, it's about 3%. So it could be that she has having routine gallstones and we don't need to look too much into it. She has asymptomatic CBD dilatation. There is no evidence of any stone in the CBD, and the EUS is also normal. So I would not give more credence to the CBD dilatation, and LFT was also normal. However, an open surgery can always put the patient at risk for adhesions. She also had an open appendectomy at the same age, and now we do not know the indication of appendectomy, whether she had any symptoms at all. Since it was a subcostal incision, I presume that cholecystectomy was the primary procedure, and subsequently she has never had lower gut symptoms. CECT and PET are also unremarkable in the right lower quadrant. But we have to consider a possibility of Crohn's, because after appendectomy, there is an increased association with Crohn's disease. The most important thing she had in her past history was renal cell carcinoma at the age of 29. Normally, the age of presentation is about 50 plus, but here at the age of 29, we are seeing a young patient presenting with renal cell carcinoma. It was on the left side. We do not know the nature of the lesion, whether it was clear cell or papillary or other forms. She underwent an open nephrectomy. Now, very important, usually in renal cell carcinoma, we do not give radiotherapy. This patient underwent radiotherapy at the site, which can be, so possibly it was not an R0 resection, or maybe it was an unusual kind of tumor. And usually RCC, the clear cell variety, is not radiosensitive. So the treating physician took a decision to give radiotherapy. And we can see that the local muscle is atrophied. You can see on the right side, it is a good bulk, and on the left side, it's completely atrophic. And here we can see most probably the site of incision on the CT scan. We do not know the follow-up status for RCC. RCC in general has good prognosis, especially the clear cell variety. However, the papillary variety has a poorer prognosis. This patient developed RCC when she was young. There are no existing risk factors in the form of tobacco, obesity, hypertension, CKD, acquired cysts, or estrogen therapy. So I suspect that in a patient without any risk at such a young age, when they have had, we should consider hereditary syndromes. However, this patient did not give any positive family history. Family history may be absent in 25% of patients. And the three hereditary cancer syndromes which come to my mind are the VHL gene mutations, which usually is associated with clear cell RCC. However, 2/3 of them have renal cysts. This patient doesn't have any renal cyst on the right side. They can have bilateral involvement. This patient has no evidence of bilateral involvement. It can be multifocal RCC. We are not seeing that. And they have associated hemangioblastoma of CNS and retina, and have a strong family history positive because it's autosomal dominant. We have not seen anything like this in our patient. The other possibility is hereditary leiomyomatosis and RCC syndrome. This patient had a small uterine fibroid. This is also a very common finding in women, so I will not give so much of credence to it. However, it is associated with aggressive papillary cancer. In our patient, we did not have an aggressive disease. It can have extensive metastasis, but the important thing about papillary cancers is they are not as hypervascular as are RCCs. So they also have cutaneous lesions, none of which our patient had. The third possibility is Birt-Hogg-Dubé syndrome, where the skin has fibrofolliculomas. This patient did not have. However, Asian patients are supposed to have lesser incidence of fibrofolliculomas. Lung, this patient has evidence of pulmonary cyst on the CT scan, and kidney can show multifocal renal tumor. In our patient, we do not know what was the nature of the renal tumor at that point of time. But the interesting thing about this syndrome is that they have the chromophobe type of cells which are malignant, and they have an oncocytoma. Both of these are not usually hypervascular, and they are not FDG PET await. So I would just suggest you to keep this in your mind as we go further. So we have the clear cell carcinoma, which is the conventional 70 to 80% have clear cell carcinoma. These are the classical hypervascular lesions. The VHL gene mutations also associated predominantly with clear cell carcinoma. Papillary renal cell carcinoma occurs in 13 to 20%. It can be multifocal, bilateral, and these are not so vascular, and they may be associated with hereditary cancer syndromes. The chromophobe type also has a very good prognosis, and it is also not so vascular, and it may be associated with the Birt-Hogg-Dubé syndrome. See, other things are fairly uncommon. Only mention here is of sarcomodoid renal cell carcinoma, because again, this is not such a vascular thing, but it's a very aggressive tumor. So in a classical clear cell RCC, you can see that as soon as you give IV contrast, there is increase in the vascularity of the kidney. So you can see a hypervascular tumor, which has rapid washout. Whereas in papillary cancer, you can see that it virtually looks like a cystic kind of a lesion and has a delayed enhancement and a slower enhancement. So this can be mistaken as a low vascular tumor. And here you can see oncocytoma. Again, here also it enhances better than the papillary cell cancer, but however has to be differentiated from the RCC. This patient also had pulmonary tuberculosis. We do not know the basis. We do not know the response. And there was no ileocecal involvement. Right now, PET shows right hilar nodes, but lung has no tubercular lesions. In this patient has presented with small bowel obstruction. We know pulmonary tuberculosis can be associated with ileal involvement. So, which is something which we just want to bring it to light. Now, let us come to the main component of this patient's present problem, that is jejunal obstruction. Jejunal obstruction in this patient is chronic. It was insidious onset, progressive, high gut obstruction, partial because the gastrographin went past. She never had obstipation or constipation. It did not have any clinical features of ischemia. It was not resolving and warranted surgery. So what are the possibilities given this? Adhesions, which we have already documented on the CT scan. She had radiotherapy that could be inducing a stricture. She could have Crohn's disease, there's excess vascularity and presentation with obstruction. A second malignancy could be a possibility because this patient may have a genetic mutation since she had her first malignancy at a young age. The other possibility is post-radiotherapy, there can be a local increased risk of malignancy. She could also be metastasizing from RCC. RCC usually metastasis up to 20 years is noted. This patient is 30 years down the line. So if we look at the symptoms which the patient has, it was self-induced, painless, non-projectile vomiting despite significantly dilated loops. So this tells me that it was a slowly progressive disease. The next thing is the significant weight loss, which could happen due to three reasons. Either due to inflammation, we have no markers of inflammation, could be due to a malignancy, it could be due to reduced intake. But this patient was a doctor, most probably must have been taking care of her diet in whatever best way possible. So I expect that malignancy is a strong possibility. All inflammatory markers negative, so Crohn's, TB, eosinophilic enteritis seem unlikely. There is no fever, so Crohn's, TB, lymphoma again becomes less likely. The jejunal obstruction which the patient has, there was no diarrhea. It's a very important feature in this patient that she went on to have obstruction without much of mucosal symptomatology. So Crohn's, TB, celiac, lymphoma, ulcerative jejunitis seem less likely. There was no GI bleed. Again, with mucosal tumors, you will find GI bleed in the form of adenocarcinoma, polyps, cysts, angiosarcomas. Angiosarcomas are specially associated in post-radiotherapy situation. So in this patient, there has been no anemia, no history of GI bleed. That makes these causes less likely. There was no pain, so there is no feature of acute obstruction, inflammation, rapidly growing tumors and ischemia. These seem unlikely. And there was no distension. It's a very important thing that usually we teach undergraduates and postgraduates that distension is a very important feature in upper gut obstructions. Or any small bowel obstructions, but in this patient, maybe the loops which are dilated are the duodenum and the jejunum, which are all stuck to the posterior wall. So maybe that is not visible anteriorly, and that is the reason there is no distension. So intestinal obstruction could have been due to an intraluminal cause or intramural, that means in the wall, or extrinsic causes. And here we can see that intraluminals are bezoars, foreign body, fecal matter, gallstones, and polypoidal neoplasms. And we can see that those are unlikely. We have no evidence. Gallstones is possible because the patient had a past history of gallstone. Gallstone ileus can present. However, patient has no CBD stone, no radiopaque calculi on CT, so this is unlikely. Polypoidal intraluminal masses are unlikely because we are not seeing a definite mass, no GI bleed, and no anemia. And intramural causes like congenital atresias, diverticulitis, intersusception, anastomotic strictures are unlikely in this patient. So I will exclude them. Carcinoma affecting the wall of the gut, ischemia, radiation injury, and Crohn's are still possibilities. And among the extrinsic thing, again, congenital bands, abscesses, endometriosis, volvulus are out. So we still have to consider a possibility of hernias, adhesions, and carcinomatosis. So now what do we have with us right now? We have these possibilities remain, that is adhesions, carcinomatosis, that means from the peritoneal side there is involvement and involvement of the bowel from serosa into towards the mucosa, which can cause thickening of the bowel wall. There could be an internal hernia because many times you can get a mesocolic hernia in a patient after nephrectomy. Intramurally, you can have malignancies like lymphoma, NET, and RCC. These were the three ones which are not PET avid. Ischemia can be there, radiation injury, and Crohn's. So we'll just discuss this in brief. Adhesions, patient has had 2 open surgeries and the CT shows evidence of clumped up bowel loops. And adhesions are the commonest cause of obstruction in patients who are undergoing any abdominal surgery. So in a set of series of 1 lakh patients undergoing surgery, 9% developed small intestinal bowel obstruction, 56% were due to adhesions, and adhesions are reported in our patient CT, and there can be partial persistent obstruction of the gut, which is what the patient of ours had. However, symptom onset after 27 years after the surgery, progressive symptomatology with weight loss and worsening cannot be explained by adhesions alone. So we have to look for something in addition to that. Radiation can cause delayed onset disease, and here we can see that there was fixed loops in that renal fossa. There was muscle atrophy, so significant radiation was given. Weight loss is also a feature because of mucosal injury, and segmental bowel thickening and FDG PET negative status is a very common thing with radiation-induced enteritis. Small bowel injury. However, the onset has been very late, though till 30 years it has been reported. This patient had no mucosal symptomatology at all. In radiation, 2 things get affected, that is the stem cells of the intestinal lining, and the second thing is the vasculature. There has been no evidence whatsoever in this patient. So though it is a common problem in the post radiotherapy status, I would still not consider it very likely. Next is internal hernias. When we have internal hernias, you can see that here you can see the small bowel loops have gone behind and occupied after nephrectomy the renal fossa area. So this is a normal phenomenon because now the renal fossa area is now empty. However, during surgery, there can be a problem that we can see that this is the Girota's fascia, which has to be dissected along this plane. Sometimes during this dissection, it is difficult and the mesocolon is just anterior to it. Suppose a nick happens, the surgeon tries and sews it. If it is a large one, they sometimes leave it open. And you can see that it is a very thin plane of dissection they have to do in a patient. And in this patient who has undergone a nephrectomy and had radiotherapy after that, I suspect that it was a difficult resection. They may have found not an R0 resection. So there could have been a chance of injury into the mesocolon through which the small bowel can herniate. And this herniation can present like that with intestinal obstruction. And this is the defect which can be seen. However, our patient never had any episode of acute obstruction. The next possibility is malignancy. And here we have to spend a few minutes on this. The patient has had a nephrectomy for a renal cell cancer, has presented with small bowel obstruction, insidious onset with weight loss and progressive worsening. And the lesion is FDG PET negative. But we are not finding any definite mass lesion, no ascites. It has come after 30 years, which is a fairly long gap. And there has been no acute event in the history. And we know that this is another patient's picture where you can see dilated loops and a thickened bowel wall, which is associated with obstruction. Malignancy, 5 to 10% of GI obstructions are due to malignancy. More than 90% is secondary to small intestinal tumor, and metastatic involvement of small bowel is very common. It's usually in the diffuse form like a peritoneal carcinomatosis. It may not be associated with ascites. Long gaps are reported, especially with RCC and malignant melanomas. They may have non-specific symptoms. They need high index of suspicion and often misattributed to adhesions as in our patient. So the primary lesions which can present like that are adenocarcinoma, lymphoma, and NET. And secondaries are breast cancer, lung cancer, melanoma, ovary, and RCC. So 6% patient in that series had RCC as a cause of small bowel obstruction. RCC recurrence is very common. Metastasis occurs to 25 to 50% of people develop metastasis. In fact, 1/3 have metastasis at the time of diagnosis, and 11% will develop after 10 years of diagnosis. So a strict follow-up was recommended. In our patient, no follow-up was happening. 2% of all the metastasis in the small bowel, and RCC can spread through lymphatic route, hematogenous, transcoelomic, and direct invasion. And metastasis may be hypervascular in the setting of a clear cell and will have a low PET avidity. However, it can also be hypovascular if the patient has a papillary cancer or an oncocytoma. Small bowel involvement in RCC, there are more than 20 to 30 case reports of various types, and what they have found is either a polyp in the stomach, in the small bowel, an ulcer, a submucosal tumor, or a serosal deposit. The patients can present with bleed, pain, obstruction, intersusception, perforation, and weight loss. Our patient had both of these. The timing can be metachronous or synchronous. It has been reported from 3 months to 20 years of age. It increases with age, and the mean age is 61 years with metastasis. Our patient was 60 years old, and the size can vary with a maximum size of 8 to 5 centimeter. The number of polyps can be 1 to 70, and jejunum is a common site, and the mechanism is by shower of emboli, as well as also in the local surgical bed there can be recurrence. So in our patient, most probably it was not an R0 resection, that's why they gave a radiotherapy, or it was an unusual kind of tumor for which they gave a radiotherapy. NETs are also a possibility, but however, NETs may have calcification, may have desmoplastic reaction, and all this can result in associated obstruction. In our patient, the CT picture is not typical of an NET, and weight loss is also not such a prominent feature in NET, but NETs can be FDG PET negative. Lymphoma is another possibility, especially patient has received radiation there. But usually there is a thickening of the small bowel. Here in our patient, there was not such a kind of gross thickening of the small bowel. And quite often they can have also aneurysmal dilatation of the bowel, which we did not see in our patient. But low-grade mantle cell lymphomas can have FDG negative and just a thickening of the bowel. And presentation with isolated obstruction is not so common. They would have had associated pain or diarrhea, which our patient doesn't have. So absence of pain is a very important feature in this patient. Maybe her pain tolerance was high. And then ischemia is also a possibility. There was evidence of aortic calcification. However, there was no feature of any mucosal edema or thickening of the mucosa to suggest a ischemic event of the gut. Crohn's disease remains a possibility. Patient has had an appendectomy, segmental thickening of the bowel, and CT showed increased vascularity. There was a Coombs sign. Small bowel obstruction is a very classical presentation of Crohn's disease, and weight loss is also very common. However, very important here to note that jejunum is not the most common site. Ileum and colon were totally normal. Patient's CRP was always normal. There was no pain, no diarrhea. And Crohn's disease, if it is active, it is FDG avid. However, a residual stricture may not be FDG avid. But this patient has symptoms which are only of 3 years origin. So I would have expected an FDG avid area in the, if it was Crohn's disease. So my final diagnosis is jejunal obstruction due to jejunal metastasis from RCC. Along with that, there are definitely adhesions. There could be also post-radiotherapy induced chronic small bowel injury, a post-operative internal hernia, maybe a mesocolic hernia. It's a possibility. It's a wild guess. I cannot negate it, but however, I cannot, put my I will not go further on that. Left renal cell carcinoma, we do not know what was the nature, whether it was a clear cell or a papillary or an oncocytoma. Because it happened at a young age, we do not know whether she has any mutations like hereditary RCC syndromes, which can also present later on with secondary metastasis. And she received radiotherapy, so it tells me it was not possibly an R0 resection or an unusual type of tumor. Pulmonary tuberculosis is treated. There are some residual hilar nodes. We do not know whether it's a metastasis from RCC or is it a part of the tuberculosis. She has hypertension, post-appendectomy status, and a post-cholecystectomy CBD dilatation. Thank you.
Thank you so much, madam, for this comprehensive discussion. And I can say at this stage, you are quite close. I would request you to just stop the screen sharing. Yeah. And as we have Dr. Professor Raju Sharma here, so we'd like to hear you from you, sir, if you have any additional point to add.
Congratulations, Usha. I'd like to congratulate you for that very exhaustive and comprehensive description of the case and a very astute description of the radiology. except for saying that it's life-threatening for a radiologist to see clinicians like this when they describe the radiology so accurately. I have very little to add. When we interpreted the CT angiography of the 62-year-old physician, our interpretation was that the stomach was grossly distended, the small bowel loops, the proximal jejunum was, the duodenum and proximal jejunum was dilated. There was kinking. So I'm not going to run through the images in the interest of time, but our interpretation was that the duodenum was dilated. There were adhesions, both enteroenteric as well as enteroparietal, to the lateral abdominal wall. There was bowel wall thickening, which was symmetric. In view of the symmetric bowel wall thickening and the negative PET CT, we did not consider malignancy as a serious possibility at any point when we were looking at this case in the real world situation. So our interpretation was essentially adhesions or chronic radiation enteritis causing proximal small bowel obstruction. We did not give any importance to the dilated CBD because in a post-cholecystectomy patient, the CBD diameter can be normally up to a centimeter. So we ignored that completely. If you have any specific questions, I'd be happy to answer that.
Yeah, I think I agree with you entirely that if in a routine real life situation, I would have also considered adhesions as the commonest possibility. But however, certain things were odd in this patient. That's why I had to look very closely in. And since it was a CPC, I knew I had to cover all stones and ensure that.
Absolutely. You are looking at it through the lens of a CPC and you've got to think of all the unusual possibilities.
Thank you so much, sir. Now, Professor Vinita Ahuja and Dr. Saurabh Kedi are present here from the teaching unit. I would request you to please comment if you have anything to share.
Good afternoon, ma'am.
Good afternoon, sir.
Congratulations on behalf of the department for the excellent overview and excellent presentation. So this patient, when the patient was admitted with us, so the only positive complaint of the patient was recurrent vomiting, and that was also self-induced. She never had any pain, any history of obstruction, and she had come with a CT which had shown dilated proximal bowel. And after discussing the CT with our radiologist, our possibility again was adhesive obstruction. And that is why we had gone for the gastrographic challenge after consultation with Dr. Dash and the GI surgery team. But after the gastrographic study, also the obstruction did not resolve, and the patient was having persistent symptoms and persistent vomiting, and that is why we had then considered the patient for surgery. So to discuss the intraoperative findings, I would like to invite Dr. Dash. Thank you.
Few seconds just to get my slides on. Thank you, ma'am. This just to summarize, this patient was a case of post-nephrectomy 30 years back and was having subacute intestinal obstruction off and on for a long time, and admitted to a hospital quite a few times with acute obstruction, managed conservatively and improved. So here also she waited for a long time, not improving, and there were increased bowel sounds on clinical examination. We knew that she is in some sort of obstruction. And when we had this barium, there was no doubt that these are very dilated loops and also collapsed loops. And after a long time, small amount of contrast was going down. And there were clumps of bowel loops in one quadrant corresponding to the area of nephrectomy. And the PET scan was not showing any uptake. So the differential diagnosis were, according to us, the first was a adhesive intestinal obstruction, which can occur at any stage after any day of surgery. Second is radiation enteritis, ideally 2 to 4 years, but it was a long time. We have seen they've been presenting after a long time. Third one was a metastasis from the renal cell carcinoma, which in more than half cases is PET negative. We did bring in the differential diagnosis, the inflammatory bowel disease. We do see Crohn's without bleeding, coming with obstruction in emergency also. So, but just to summarize that, whatever you said, we almost considered all of them minus the lymphoma part, which you said. We explored this patient, and you can see the video. This is to compare a normal bowel with the abnormal bowel. Now we will slowly and steadily follow the bowel from ileocecal junction. Can you sound? Mute the sound. Because during the surgery, I had almost got the diagnosis. That's why I'm muting. So this is normal bowel. We are going proximally. This is normal. Ileum, normal. Still normal. From here, there's some whitish patches are appearing with thickened bowel loops, with intermittent narrowing, no lymph nodes, no adhesions. And there are more of white patches. Those look like more obstructed lymphatics or chylonymphatic ducts, maybe due to radiation or long-standing fibrosis. So this was a 70 to 80 centimeter segment, starting from about 20 to about a feet from DJ flexure and extending for 70 centimeter. The proximal bowel was hugely dilated, but she was on nasogastric aspiration for a long time, so they had almost come back to normal. So this is the picture which shows this is the normal bowel and this is the abnormal bowel, and this is the transition period. So you can the transition segment. You can see that there were whitish, little bit yellowish, but mostly whitish patches. No creeping of the mesentery, no lymph nodes. So that was it. Then we had to do a intraoperative enteroscopy. These are the pictures. Saurav, would you like to say? So these were the pictures.
So the enteroscopy was done at about 15 centimeters distal to the DJ flexure. And when we entered the bowel, this was the appearance of the small bowel. The folds were edematous with whitish spots. And we went on, and these changes persisted till the proximal ileum, although decreasing in intensity. And at 2 points, there was narrowing of the bowel wall. And although the scope could be negotiated through the narrowing, there was no ulcer, no growth, no inflammation, only thickened folds with edema and whitish spots throughout the examined bowel.
The differential diagnosis at this stage were first again changed to radiation, maybe some chylonymphatic problem occurring there, and strictures were there, but they were passable. Question was to remove that segment because it's quite a long one, but in view of the symptoms, so we decided to take it out. We are unable to exclude a malignancy also. So we resected and did the segment, the entire abnormal segment, and did an end-to-end anastomosis. The patient uneventfully recovered in post-operative period, orally started on post of day 5, and she was discharged on post of day 12. And we had contacted her about a week back, and she's doing perfectly fine. So any opinion on this, ma'am?
No, definitely this looks very interesting, and we can see that there is a transition, and the involved segment is definitely not looking healthy. There is strictures and there is serosal form of involvement, and there is also lymphangiectasia. So I wanted to know the lymph node status.
There were no abnormal lymph nodes because the mesentery was thickened in that segment. Might be normal size lymph node inside that, but separately you couldn't find any abnormal lymph nodes.
Okay. Thank you.
So thank you, ma'am, and thank you, sir. Any comment from the house, because we have less time? Any quick comments? Okay, otherwise we are going ahead with the pathology presentation. So you all know the summary. This was what we were provided, and we knew that patient had a surgery for renal cell carcinoma, and she had a history of radiotherapy with cholecystectomy and appendectomy performed 30 years back. And there was 40 centimeter distal to the DJ junction. The jejunum was thickened, and there were some yellow colored patches in the serosa that we have seen. So clinical diagnosis mentioned in the requisition form was inflammatory bowel disease, as was said, radiation induced changes and subacute intestinal obstruction query cause. So we received about 80 centimeter long of small intestine, and as you can see, there are no definite stricture. We could not identify both on the serosal aspect and mucosal aspect. But what we could identify, these are two narrow areas on the serosal aspect, and on both of these areas we could identify some small nodules or some lumpy areas which is yellow in color on the serosal aspect. Rest of the mucosa was almost unremarkable. This is the closer view of the mucosa just opposite to the area of narrowing. There is no stricture, no ulcer. And this is closer view just to show you if there is adhesion or serositis, we see the serosa become very opaque and thickened. Okay, here we could not identify such changes. Instead, we can see some yellowish nodule here and there. And this is the cut surface of the mucosa. This is the mucosal layer. You can see some yellowish nodule also can be seen just below the mucosa, and they are also present on the serosal aspect of the cut. So now going to the histological finding. On low power, the mucosa in most of the areas of the gut was unremarkable. There was no feature of inflammatory bowel disease in the form of chronicity of the crypt architecture or any active inflammation or basal plasmacytosis. And this is the high power picture just to show you the mucosa in most of the areas. It was almost unremarkable. Tall villi, no increase in intraepithelial lymphocytes, and the inflammatory infiltrate was also not abnormal. There was no atypical cells. We could not identify any granuloma anywhere, but on low power examination, the most important finding or which caught our eyeball is this type of thinning and thickening of the bowel wall. This is the muscularis propria. You can see the thickness is quite variable. Also here you can see the same changes, and in between there are some whitish patches we can see on low power. Here also you can see this is the muscle, how it looks like, but these are the white patches what you can see. So here this is further higher power just to show the mucosa and submucosa is unremarkable, but the muscularis propria from the thickened area, we can see some clear cells here. They are singly almost looking like infiltrating the muscle layer. This is one of those nodules on low power view. You can see the nodule is very circumscribed, and there are clear areas surrounded by some lymphocytes and some fibrosis. And these cells are also infiltrating the muscularis propria and focally into the submucosa also. This is Masson's trichome stain, which actually highlights the collagen, and here you can see some collagen deposit around those nodules, but the nodule is predominantly comprised of such clear cells, okay? And so fibrosis or collagenization was also seen in the overlying muscularis propria in a patchy manner. This is high power just to show you. These are the clear cells I was talking about with a central small nuclei. The nuclei is not pleomorphic. So primarily it did not appear as tumor cells to us, but as there was a history of RCC, so we thought it can be RCC infiltration. So primarily we identified clear cells surrounded by fibrosis, which is also infiltrating the bowel wall. Some of the clear cells were also having this type of yellowish pigmented dots. They were not very eosinophilic, what we see in Whipple's disease and other diseases. And this is the closer view just to show these clear cells. They are individually infiltrating the muscle layer. Okay, this is the nodule. This is the area of infiltration and fibrosis. So they are basically eating up the muscle layer around these nodules. And here you can see these are the clear cells I just talked about, and here it is infiltrating the muscularis propria, and see the nature of destruction of the muscular wall. Okay, and in between all this pale area, this is basically collagen deposition. So there is infiltration of these clear cells, as well as there is extensive fibrosis which is replacing the muscle. Very focally, we very closely examine the muscle, the mucosa, and only 1 or 2 foci we could identify some clear cell infiltration into the lamina propria. But in other areas, it was mainly restricted to the muscle, serosa, and focally into the submucosa. So this is the area I get to show you with areas of collagenization. This is the area of collagenization, and these are the muscle which is residual, and these are the clear cells. Again, the same thing. Here you can see in this area, and it was in we identified this type of changes almost throughout the length of the small bowel. Here you can see it is extensively replacing the muscle, and everything is basically replaced by fibrosis. This is the Mason's trichome stain, just to show there is perimuscular fibrosis in between. And this is the SMA stain, which is highlighting residual smooth muscle actin in the smooth muscle, and rest of the area is basically area of fibrosis and the clear cells. And most importantly, we also try to examine if there is loss of ganglion cells, but ganglion cells are quite clearly identifiable. Very patchily, we could identify some fibroelastic change in the submucosa, and very interestingly, these clear cells were seen to infiltrate around the blood vessels, and the blood vessels showed hyalinization and very remarkable thickening, okay, and narrowing of the lumen. In addition, there are features of lymphangiectasia. You can see there is a dilated lymphatic into the lamina propria, and this is a dilated lymphatic into the submucosa. This is a higher power, just to show the very hyalinized and thickened blood vessels, and these are the clear cells. And this is the serious red stain, which also highlights the collagen area. You can identify very patchy nature of this irregular fibrosis, which is actually replacing the dying muscle cells. And these are the areas of fibroelastosis I showed into the submucosa. There collagen is very less. These are basically formed by elastic fibers. And very focally, we could identify fibrointimal proliferation of the blood vessels and ischemic change of the surface of the mucosa. The lymph nodes were almost normal. We could not identify any granuloma or any clear cells because we are considering RCC metastasis, and there was no feature of amyloid deposit. So till now, our predominant finding is this infiltrating clear cells. Okay, so this is our predominant finding. So based on that, we considered a metastatic clear cell RCC or metastatic clear cell papillary RCC, because papillary RCC and conventional RCC, they show this type of clear cell changes. We also could not rule out a metastatic breast carcinoma, which might be a very small lesion. So hence, we thought there can be incidental breast carcinoma, or then we considered post radiotherapy changes or histiocytosis related stricture. Though at this stage, we could not rule out also changes of recurrent ischemia. Now, how to rule out if this is metastasis from the renal cell carcinoma? The PAC site is a very convincing marker, which is actually described in all RCCs which have clear cells, like clear cell RCC and clear cell papillary RCCs. Okay, and also recently the list of different histological variant of the RCC is expanding, and there are approaches which are being described, and we can see this type of clear RCCs with clear cell changes can be convincingly classified based on this T stain, CK7, carbonic anhydrase 9, and amateur. So we performed all these stains, and our tumor was negative for PAC site, then carbonic anhydrase, amateur, and CK7. We also performed cytokeratin stain and vimentin stain. If it is a RCC, both of these stain is expected to come positive. But here it came only positive for the vimentin, and CK was negative. CD10 also stains the RCC, which arises from the basically loops of the Henle. And here we can see the tumor cells or the clear cells, they are negative for the CD10. So at this stage, we could rule out most possibly this is not a metastasis from the RCC. As we also thought it can be incidental carcinoma breast metastasis. So we performed a GATA3. GATA3 usually stains most of the metastatic breast carcinoma. So it was negative. Hence, we also ruled out metastatic breast carcinoma. Now, Vimentin positive clear cells, we knew at this stage we have to work up for the histiocytic disorders. And from our daily experience, we know this is actually a section from the breast which was undergone neoadjuvant chemotherapy, and there are histiocyte predominant reaction. So this type of reaction has been described in breast and other organs in up to 10% of the specimens post NACT, and most of these lesions have been described 2 to 3 weeks after radiation therapy. But we have a question that in our patient, all these changes are predominant after 30 years with bowel stricture. So the question is, can histiocytosis cause this type of changes? We also thought to rule out other types of histiocytosis. This is 2016 classification of histiocytic disorder, which was classified into 5 types. This is the Langerhans type of histiocytosis. This is cutaneous type of histiocytosis. This is malignant histiocytosis. This is Rosai-Dorfman type of histiocytosis, and this is hemophagocytic lymphohistiocytosis. In all of them, usually CD68 stain is positive, but based on S100, CD1A, CD207 or Langerhans stain, and CD21, we can actually classify the type of histiocytosis. In our case, the cells are positive for CD68. They were also positive for S100 and CD163. However, they were negative for CD1A, which is a marker of Langerhans type of histiocytosis. These cells are also negative for CD21, which is a receptor for the Epstein-Barr virus and comes positive in the malignant type of histiocytosis. In our case, there was also no pleomorphism, so we could rule out that. And HMB45 we just performed just to see if it is a metastasis from malignant melanoma or not. It also came negative. So to summarize, these clear cells were positive for CD68, S100, 163, and they were negative for CD1A and CD21. Hence, we thought this can be a non-Langerhans type of histiocytosis. Now, type of histiocytosis, the cause of histiocytosis worked up. We did a pass with diastase stain, and as there is no pass positive diastase resistant granule, we could rule out malakoplakia or possibility of a Whipple's disease or Gaucher's disease. Okay, they all show positivity for pass. We also tried to rule out by doing a ZN stain if there is any Mycobacterium avium infection or not. They were negative. And on closer look, what additional finding, we could identify that there are small tiny vacuoles within the clear cell cytoplasm. These are actually represent fat vacuoles. Hence, we named this type of non-Langerhans histiocytosis as a xanthomatosis. Now, xanthomatosis, it is the most common in the tendons and skin, all of you know, but in the intestine, it is commonly described in the stomach and in the sigmoid colon. It is rare in the small bowel, and esophagus, only 1 or 2 cases has been reported. It is usually identified incidentally during endoscopy. Among the symptomatic cases, it can cause obstruction and stricture. Most of the GI related histiocytosis or xanthomatosis, they are non-dyslipidemic. In our patient also, the lipid profile was normal. However, dyslipidemia associated xanthomatosis also has been described in the GI tract. This type of xanthomatosis can be seen in HIV patients who are having diabetes for a long time and who are infected very frequently. And sometimes no cause has been identified. Now, if we look into the literature, this type of intestinal xanthomatosis can be either diffuse or it can be nodular, almost form a tumor-like mass. So this is called xanthomatous pseudotumor, and this is called xanthomatous diffuse xanthomatosis. In addition, we can have polyp formation like this. This is a gastric xanthoma with a polyp-like structure with clear cells in the lamina propria, which has been highlighted. This is an example from ascending colon. If we look into the literature, the xanthomata pseudotumor, they are most commonly described either in the neck mass, or they presented as a mass in the spleen, or a breast mass post-NSCT, or they have been identified in the small intestine. In almost all the cases, they were either had a diffuse large B-cell lymphoma. Okay, one case had breast carcinoma post-NSCT, and this patient, a boy, had Burkitt's lymphoma. So what we could identify that the pseudotumor like histioxanthomatosis is more commonly present outside intestine. On the other hand, if we look into the intestinal type of xanthomatosis, it has been described in the stomach and large intestine, though case reports are very rare. And both in these areas, it usually localized at present as a polyp. On the other hand, small intestinal xanthomatosis is always mostly diffuse type of xanthomatosis like this, and I will ask you to look into this, put attention to this case report, where this type of xanthomatosis, diffuse xanthomatosis of the small intestine, was described after 20 years after radiation therapy of the right hip, because this patient was having AIIMS sarcoma. Okay. And there are actually 8 or 9 cases of diffuse xanthomatosis of the small intestine is described, and in most of the cases, see, they are related with the previous radiotherapy and chemotherapy. This patient had cholangiocarcinoma, Burkitt's lymphoma, multiple myeloma, and AIIMS sarcoma of the hip I already have shown. Actually, Butler SM et al. Reported a case in 1978. This case only, they described his xanthomatosis resembling scleroderma following multiple myeloma in the intestine. Okay, and this is the radiological picture, almost resembling in the present case. So what can be the cause of myocyte destruction and fibrosis, because we are describing it as a xanthomatosis and benign condition. It is known that xanthomatosis can be seen acutely because of tumor necrosis and release of chemotactic factors, but delayed changes of xanthomatosis can be an adaptive change because of release of cytokines, and recurrent ischemia may be a cause. In this case, we identified some feature of mucosal ischemia. Infection can also produce this type of small intestinal xanthomatosis. In our cases, we could identify this type of thickened vessel, and these clear cells are encircling the thickened blood vessels. Now also, I showed you the fibroelastotic changes in the intestine. The fibroelastotic changes, this has been described in patients undergoing intervention or previous irradiation in cases of GI lymphoma, patients who had multiple myeloma and long-term GRD. And as we have seen, the fibroelastosis and prominent collagenization and the thickened blood vessels, so it is quite clear that our patient had post-radiotherapy induced changes. Okay, so to summarize, this is our final diagnosis. This is a jejunal diffuse non-lipemic xanthomatosis with fibroelastosis and ischemic mucosal changes in a patient with RCC who presented to us with symptoms 30-year post-radiotherapy. And what we could learn from this very rare case, that small bowel xanthomatosis can be diffuse, okay, and small bowel xanthomatosis are rarely associated with dyslipidemia, and it can be a long-term complication of post-radiotherapy and chemotherapy, or it can be a complication of recurrent ischemia. Patient with a known history of radiation or chemotherapy may present with xanthomatosis-related obstruction several years post-radiation therapy. So along with all other differentials we discussed, this rare complication should be kept into the mind. And this case, all from the different department, everyone helped to work up this case. We are grateful to them. And now the case is open for ma'am's comment and open for any comment from the house. So thank you.
Thank you, Dr. Prasenjit, for an excellent description of the histopathology. It's interesting to see a new diagnosis prop up in that sense. Till the level of clear cell, I think we went right from the clinician's point of view. So after that comes the huge markers, which are, are beyond clinicians to fathom which way you are taking us. So I really want to ask you two questions. That RCC also, when there can have vimentin positivity when it is infiltrating the tissue. So vimentin positivity is known in RCC. Second is, what are the specific markers you can do to say that this is of renal origin? And were all of them negative? The third question is, these cells are usually macrophage in origin. So have you shown that these cells are macrophage origin markers positive? And the fourth question is there any suggestion that there's, cholesterol within each of these cells? Usually those are the xanthomas which will have cholesterol within them. So I didn't remember you showing me any slide showing that there is fat inside these cells.
Thank you, ma'am, for very relevant questions. You are right, the RCC cells, they are positive for the vimentin, but side by side, they are also positive for the cytokeratin. And as I have told you or showed you, carbonic anhydrase 9, CD10, then Amaker and CK7. They are usually positive in all type of clear cell type of RCC. That is conventional clear cell RCC, papillary clear cell RCC. So it will be positive. All the markers were negative in our case. And secondly, histiocytic origin. We showed you, apart from being vimentin positive, these cells are positive for the CD68, S100 as well as CD163. So these are quite enough evidence to give them or call them as a histiocytic disorder. And secondly, you are very right. I did not show you if those small vacuoles within the cytoplasm are actually fat vacuoles or not. Actually, fat staining can only be done in frozen section, but we did not anticipate it in this case that we will encounter such a rare diagnosis. So we did not have any frozen tissue preserved. So on the formalin fixed tissue, we cannot actually do staining. That's why I did not show you. But those small fat vacuoles under microscopy are quite suggestive that they are having fat actually in the cytoplasm. That's why we make it xanthomatosis.
So, an oncocytoma, could you exclude?
Ma'am, oncocytoma actually, they are sometimes S100 positive, but the appearance of the cells will be totally different. We'll have very eosinophilic granular cytoplasm. In this case, we were having particularly clear cells. There was no eosinophilic granules into the cytoplasm. That's why we did not consider that. We also tried to review the previous slide or blog, but that were not available because she was operated 30 years back.
Just one more question I have for you is that, sorry, I forgot. I had one more question. Is that, yeah, so in the literature, there are about 20-30 cases of jejunal involvement by RCC in the form of obstruction, again, clear cell origin. So do you think they were all this particular entity you are discussing, or could they have been really RCC, or do you think they didn't look at it so closely as you did?
Ma'am, both of the disorder can show you under microscope clear cells. But as we have step by step excluded a possibility of RCC, we have to really look into the previous reported cases if they could do all those IHC or not, because they can be on either way. But I believe before reporting, they have already done all the panel of markers to rule out basically histiocytic disorder also. That's why they reported it as a RCC, because our cells were negative for all the panels or markers we used, which are directed towards the renal cell carcinoma.
Just as a clinician, I still have my doubts, because the only reason I have my doubts is why is it affecting only a localized part of the gut, which is in the left renal fossa and not the other parts of the gut. They were all healthy. The surgeon showed us all healthy. So why is it that this disease is only at the localized site? Is it because radiotherapy has triggered it?
Ma'am, it can be because in the literature I tried to see what is the basically reason behind it. Most of the lesions have been described either in the sigmoid colon and in the jejunum, and very rarely in the other side. But I cannot give you a exact explanation for that, why only jejunum is being affected in this case. But it is one of the commonest sites which has been reported in all these 8 or 9 cases, what I mentioned.
Okay, thank you so much.
Thank you. Any other question or comment?
No, after all these discussions, actually, I have a question now. Now, My first question is, will ever a surgeon diagnose this in his lifetime? Second is, have we done the right thing or we have to do something else?
Sir, one of the most important explanation is the diagnosis is right, that your patient is still doing well. There is, if we could have missed a tumor, there would have been other ascites or something, but there is no other feature.
Any follow-up required in this condition?
Most of the reports, what I mentioned, they said post surgery the patients are doing well. That's all.
So, if that is the final thing, and why all these investigations, scannings and all this, and finally what to do is what is the use of all this training?
I don't have any answer.
Can I ask a question to Dr. Raju Sharma, whether he had any features of any fat which was, creeping onto the intestine, or anything to suggest fat-related attenuation?
No, none at all. We never thought of fat. We never dreamt of this diagnosis. I had never heard of the entity. But those of us who remember Usha from our days of interacting with her as a resident in internal medicine and gastroenterology, remember her persistence and power of persuasion. I have never seen that again after she left this institution. And when she walked into radiology asking for any investigation, the general consensus amongst residents was just say yes and do it, because she will not give up. So on that lighter note, I think I'll congratulate you again. There was no evidence at all of fat, which you asked me on CT. We never thought of this diagnosis at all. Congratulations for a wonderful discussion.
Thank you so much. And I must take the opportunity to thank Dr. Pankaj, Dr. Naveen, and Dr. Chandan Das and Dr. Anupam, who gave their inputs, and also our nephrologist, urology surgeon, who taught me about planes of dissection. So, I learned a lot of surgery, urology, radiotherapy, and oncology, apart from gastroenterology and radiology. So it was a wonderful learning experience for me. And thanks again to my alma mater.
So in the end, I would like to thank Usha for excellent discussion and Dr. Prasenjit for the brilliant discussion, and all of you for attending this meeting. Thank you.
Thank you.